Yes. Will you show him real quick where the rest of these things? Oh, and whatever. This brown corner.
If there's any drip.
Oh, in the video.
I'm gonna switch ways with you. It's just gonna be good.
Yeah, I don't think it would let us. Right. Okay. Oh, you renamed Ashley. You renamed Ashley. It's not white, so I mean. Now.
Yes.
Bristol.
Yeah. It's okay. No, that's how we want it, right? That's how we want it, right? Yeah, yeah. Yeah, we're having a hard time. No, that's not, because there you go. That's the right one to rename. It went back to the other one. It keeps, now it's back to the right one. See, it keeps going back and forth between the two.
I don't, I gotta go to
Yeah.
I don't have any. I don't get it.
Said one for that crap for it, so.
All right. No, thank you.
Are you sitting in your office? Yeah,
you'll definitely have a unique certificate.
Let me grab her.
All set.
Yeah, so. One day, but I don't live here. Yeah.
I know. I know. I was gonna say every hour. There's
Right after you came, Aliana got that.
So which one can I place this in? So I can, oh, my bad. Which one do I pull out?
I don't know because we don't normally put in this computer. I don't know which. That's why we run this presentation.
Someone you see later.
No.
I don't know.
And so I can't come out. Man. Okay, okay, well, I will be able to move. I'm gonna do her back to school. Maybe also something.
Yeah, it's about to.
Okay, I will stay here and I'll be a good presenter.
This is on.
I know the feeling. Because I have to wander.
An opportunity to say hi.
Good afternoon, everyone.
Good afternoon.
Good afternoon.
Let me say that one more time. Good afternoon, everyone. I don't really believe you because as you look outside, so we really need to have a truth detector here. Dr. Rappaport and I were just commiserating on the fact that we shoveled snow early this morning. And then before we could pull out of our driveways, it was back on the ground 3 inches again. So what a wonderful day. I am very honored to not only welcome and introduce a friend, but a great physician, a great leader in our community. and that's Dr. Richard Ferguson. Dr. Ferguson grew up in Washington, D.C., and he knew something as a child that being from the East Coast wasn't good enough. He needed more than that. And he said that the education that he was getting, while great, he had to venture to the Midwest. And not just the Midwest, he had to go to Chicago. And by now you should realize that I am from Chicago. Dr. Ferguson went to Northwestern University, earning a degree in genetics. He then said, well, I just don't want to leave the Midwest, so I need to go up to Michigan State, staying in that area. And he went to school there for his medical school degree and at the College of Human and Medicine at Michigan State in East Lansing. He is a board certified in family medicine from the University of Utah, and he has practiced emergency medicine and clinical access facilities throughout our nation. He was also completed, I mean, he's a very motivated guy. He has a MBA here from the Echo School of Business, and he was granted that in 2020. You could say that he's an overachiever. I thought that just going to the Midwest and being in Chicago was good enough. Not for Dr. Ferguson. He said, let me go to the Army. I haven't been challenged. So he was a battalion and brigade surgeon for 7 years there, serving in Operation Iraqi and Enduring Freedom. Dr. Ferguson has commented on the fact, that, quote, one of the most impactful times of my life as a physician was in care for my soldiers and their families abroad, end quote. In 2021, Dr. Ferguson established the Black Physicians of Utah to improve health care outcomes for Blacks and underrepresented Utahns by increasing the number of Black physicians in the state and through multiple health education initiatives. Dr. Ferguson stays busy. He's always doing talks, and when you call him to ask him to participate in things that'll be better for our community, he doesn't hesitate, he shows up. When we asked him to do this grand rounds, he was there. He currently works as the Chief Medical Officer for Health Choice Utah. He says he's had some spare time, but in his spare time, Dr. Ferguson has completed over 41 triathlons. I hurt just thinking about it. And he enjoys football with family and friends. I welcome Dr. Ferguson.
Well, good afternoon, everyone. Thank you, Dr. Smith. And yes, you'll learn a little bit more about how maybe I need to learn how to be more of a champion at knowing how to regulate and monitor some of my time and commitments. But when you're passionate about something, it is hard to stay away from it. So can everybody hear me okay? I feel like I need to lean into the mic a little bit. We're all right? Okay. We got some up there. All right. So I'm happy to be here today to share a little bit of my experience as a local community leader on how we can address often what is a national issue or national problem when it comes to health disparities or health inequities, but through a local lens. I'm not necessarily reinventing the wheel, but Utah is a unique landscape, has a unique culture that, what's being done in DC will not necessarily apply and fit out here. And I want to share some of my experience and some of the solutions that I feel that all programs here at the university, GME programs, can use when it comes to addressing the care of those that are Black and marginalized Utahns. So, and the reason I wanted to discuss this as a multifaceted approach is because Dr. Smith and I brought him on board when it came to our mental health aspects, but we do much more than that. That's it. Not forwarding when I just do that. I have to keep tapping that. Okay, did it go? So recently, it was MLK. We celebrated his birthday this past Monday. Black Physicians of Utah was out because we believe health equity, health access for all is very important. And it often reminds me of a particular quote that quickly flashed up there that Martin Luther King shared during one of his many speeches. And that particularly is of all the forms of injustice, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And so I often share this because it is shocking and inhumane because in many parts of our country, and as we see now, healthcare is often seen sometimes as a privilege for access. And in many other developed nations, it is not. It is considered a mandate of a citizen just being born or living in that nation. These are things that Dr. Martin Luther King saw and recognized. So what has led to BPOU? Now, of course, you heard a little bit of my bio there, background in family medicine, emergency medicine, served in the Army. But really, what was my true inspiration that led to the formation of BPOU? Because I feel laying that groundwork will give you a better sense of our future trajectory on how we're trying to address the healthcare needs of those that are underrepresented. And some of it, I'll tell you, breaking it up in about two parts. Our first part was in February 2021. So is everyone here or many people here familiar with the movie Black Men in White Coats? All right, some folks have watched it not long ago, might have seen it in med school if you're an intern. So in February 2021, I was asked to be on a panel by the Office of Health Equity and Diversity and Inclusion from Utah's medical school. And they said, I think they came to me because they didn't really know a lot of other Black male physicians to go to at the time. So I said, sure, I will be on that call. Prior to this, for several years, there is an organization called the National Medical Association. And that's an association that was developed because Black physicians in America were not allowed to be part of the AMA. So this started in the 1880s. And you often needed to be part of the AMA to actually practice in a hospital, to own a clinic, to run a clinic. So we were kept out of the healthcare system, even though many of us, or several of us, were getting our medical degrees. So the NMA started. Well, the NMA, due to some difficulty with communication and surrounding chapters not being active in our border states, Nevada, Wyoming, Montana, they didn't have active chapters. So there really wasn't an interest or thinking, is there a Black community or are there Black physicians that even need our attention in Utah? So combine that with being on a panel for Black men in white coats, that was my call to action. And as you'll see here, I'm gonna play a short, brief clip. Hopefully it plays the sound. So the last Black physician speaker there, she said there's a reason why white men and white women need to care about having more, particularly in this case, Black male physicians, but Black physicians, period. And I want to broaden that even more to having more physicians from underrepresented, marginalized groups. And I will soon take you on a little bit of a journey as to why that's so important. But this is part of that inspiration, that spark. After trying for several years to form an NMA chapter, it not really getting any traction or going anywhere. And then about a month after being on that panel, I made a vow while I was on that panel, I said, I guarantee you this year, I will start an organization that will begin to support these needs, or excuse me, address these needs. So, but that's one part of the puzzle, right? That led to the formation of BPOU. Next is really the current state of Black health in America. So, percent of adults that actually report fair or poor care, fair or poor health status. And this is as of 2020. Mind you, we were going into the pandemic at that time, but this mirrors with prior studies and surveys that were done on how healthy folks felt they were. As you can see, 18% for those that identify as Black and 13% for those that were white. And when it comes to cancer adjusted rates, in regards to particularly the impact of cancer on white and Black Americans, the disparity becomes even a little bit more apparent. And then our children, Black children aren't getting as much a chance, Black infants particularly aren't getting as much a chance or an opportunity to live long, healthy lives. Some of that's defined on where they're living, particularly zip code, but more of that is because there are structural and institution effects from systemic racism that still plague us to this day. We as frontline leaders, healthcare providers, can begin to impact this. Also, as we can see here, this I actually put up here because this shows you what increased access to care or having insurance can do. So 2010 was the start of the ACA's impact under Obama. And then, of course, we know that that mandate has gone away where everyone the healthy people needed to pay into our nationalized health insurance. However, ACA did improve and increase access for health insurance for many marginalized and underrepresented groups, thus immediately before the pandemic, increasing life expectancy for those that were from marginalized backgrounds. So we can still see there's a disparity though, as we go into the 2020s. This actually started to diverge further again. Also, adults who report being treated unfairly because of race or ethnicity when receiving healthcare. This is done not just this is not Utah. This applies to Utah, but this is nationwide. These are surveys done of tens of thousands of African Americans, white Americans, on how they feel they are being treated when they're in a patient-centered or healthcare at any point of healthcare access. This is from physical therapy appointments, OT, inpatient, ICU, sitting in there, seeing someone providing care to their family member or their child. And it's that perception that we often need to address as well. But let's focus on us. We're in Utah, right? We're a University of Utah program. So the state of health for Black and marginalized Utahns. So what I really want to emphasize here, and this shows reported fair or poor health and general health by race and ethnicity, that particularly who's leading in regards to, well, I wouldn't say leading in a poor way, when it comes to their report of their general health. We have our Pacific Islanders, African Americans, and our Native American and Alaskan Natives. And then we often can see as well as we go by income, those that are making under 25K tend to have worse healthcare outcomes or how they perceive and receive their healthcare. And also we can start, and this is where we start to get into that lens of discussion of social determinants of health and its impact. But what I found most striking, and this is from a Gardner Institute report that I read in 2021, which also said, okay, so there's not enough Black male physicians, but let's broaden that out to Black physicians, period, in the state. Also, look, when you compare the aspect on how they perceive how their general health is, it's 13% for white Utahns, and Black Utahns feel about 20% of them are in poor health. And then it expands and it's worse when it comes to Polynesian and Native American. So this is something that I said, what is a tack? What's an approach that I can take that tries to address their needs and make other providers, allied providers, aware of this disparity? Because I didn't know the data that supported it. I knew nationally, but we mirror what is occurring nationally as well. Life expectancy. So what I wanted to put up there, Utah average 80. So that's the Utah average for White Utahns, 80 years old, expected life expectancy. African Americans, 77. And then, of course, the lowest being that for our Polynesian brothers and sisters. What can we do to improve life expectancy here? Why is this disparate by several years? And then we can start to address it even by chronic disease states, particularly that of diabetes, by race and ethnicity. And as you can see here, white Utahns, about 7 to 8% are plagued or dealing with managing diabetes, 13% of Pacific Islanders, and Black Utahns, about 10%, which is mirrors that more of the national average. And then, of course, again, infant mortality, as I addressed nationally, that was the biggest graph where you saw the largest disparity. The life expectancy, I want to say it was out of 1 in 1,000 births, it was 10 times more likely that a Black infant would not make it to 6 months compared to a white infant born in America. This, of course, if you take for many cross sections when it comes to health, maternal health, diabetes, obesity, the disparity continues. And then obesity. Oh, I'm sorry that slid down a little bit on the page in the conversion. Utah dealt with obesity. Many folks may not be aware that the demographic that is most impacted when it comes to managing the health problems associated with obesity by demographic is actually Black women. When you take it might be BMI is flawed in itself if we wanted to use that as the general measurement. You know, it was developed by white Northern European men, and none of them were physicians. One was a physicist and another one was an astronomer. But we're not here to talk about BMI and how that's flawed. But we know that obesity increases one's risk for cancer, increases one's risk for cardiovascular disease, stroke, and diabetes. And it's clearly plaguing the Black and Pacific Islander community here. So some of this touches on, of course, social determinants of health. We at BPOU primarily want to address healthcare, quality, and access. So as I go in through our website a little bit, you will begin to understand we have a healthcare provider directory of providers that we feel that have been vetted by us, that are culturally competent, where we feel they are a high likelihood that they will receive unbiased and more fair care. Additionally, social and community contacts. This is often where I feel we as physicians are sometimes more removed. We stay in our clinic spaces. We're here and are often considered the ivory tower of elite academic education, but we're often not as in tune of the needs of the greater community when it comes to access and how we want to best provide care, or seemingly how is it most affordable besides putting in a referral in our EHR. We help to break down that barrier. We help to explain that with BPOU. And then next is education access and quality. This is where representation shown going into a middle school, going into a junior high, going into a public event, having a Black dentist next to me, I as a Black physician, I'm often the first Black physician that many students have met that are Black, Latino, or Polynesian in their lives, especially if they were born and raised here. Otherwise, it has been actors they've seen on television or someone that spoke to them during the pandemic that was from another studio out east. So what is our path forward to address these inequities? So part of our approach is awareness. You will see me go through in the next several slides on what I am doing to increase awareness. Part of it is being done right now in this room. Many of you, all I have to do is touch one of you, convince one of you to say, I want to be part of that change. I want there to be less health disparities. I want to know more how I can address the person that I'm providing medication assistance with. What can I do to make sure that their family is healthier and is able to live longer? It's often a really small approach, but part of it is understanding that the problem does exist. And there are some things that are sometimes a little bit more unique to Utah. As you can see, disparities are actually worse in some categories for Native American and Polynesian Utahns more than it is for African Americans. I often had to discuss this frequently when it came to COVID education. And I had many Black leaders that said, please talk about the impact of COVID on the Black community in Utah. And I go, that is not who is most being affected by COVID in Utah. And they're like, where are you saying? I'm like, our population is too small. And we are not filling the ICU and the med surge floors. It's our Latino and our Polynesian brothers and sisters that are. I want to speak to them. That's what BPOU can do. Measurement. So if anyone has gone to a BPOU event, we are very quick to send you a survey. It's often can be completed in 45 seconds or less. That is how we are trying. Much of it is qualitative, but we do a lot to follow metrics. And, I'll go into that a little bit when I close my presentation today. But we know that unless we can prove that there's a continued problem, as we know what's going on in the legislature today, they're trying to remove race from many discussions. So unless we are continuing to count the people that are impacted by health disparities, or that people that are impacted by not having access to higher education, how can we continue to fund to address the problem? So that's why measurement is very important when it comes to BPOU. Even our smallest events, if there's 6 people there, I wanted to know, did you feel like your needs were met? How can we better meet your needs? Did you like our therapist? Did the pediatrician speak to you? Did the psychiatrist spend time with you? Did you enjoy the health fair? What do you need more at our health fair? And did you feel that we were able to increase access to behavioral therapy for your child? These are all things that we try to assess after our our myriad of events. And then, of course, action. So we are trying to, or not trying, but we are actively engaged in intervention programs to address these health disparities. So some of it is through education efforts. Others, it is through providing campaigns where we support vouchers for care, particularly when it comes to mental health disorders, and breaking that and destigmatizing seeking access to have behavioral treatment within the Black community. Because we often come from a community, and Dr. Smith can attest to this, where we're considered to pray it away, or you are more so encouraged. You don't share that at home. You don't share that with me. Your grandmother went through something hard. You keep it to ourselves. And we aren't encouraged to seek care. We are trying to break that down. So that's part of our action. And then we also have the means to help people access care. We will pay for visits. Many nonprofits are doing that, or you have to prove that you're a certain point below the poverty level to have access to care. Where there's a whole bunch of folks that are before they're 200% below the poverty level to be that need mental health access and have their needs addressed. You have your single mom that makes $75K a year and has 2 kids at home, but she can't afford the deductible that she has to pay out of pocket anyhow to go see a therapist. She has to pay for all her meds. All right. There's often not a copay. And this is if she is insured. So even the insurance that people do have won't often cover mental health access and treatment. That's what we want to try to be a bridge to. Mind you, it is a drop in a bucket for what needs to be addressed, but we are taking it. And then, of course, sort of that last part of the puzzle that led to BPOU really taking off is COVID-19 in our founding. It was put out in the news, particularly in national networks, ABC, CBS, during late 2020 and early 2021 when the vaccine started coming out. There was increasing, which led to me being asked to speak to the Black community quite a bit here on what can we do to dispel the myths in the Black community about COVID. Many are, our numbers when it comes to admissions in hospitals and people getting sick. I went out to be part of COVID relief when Governor Cuomo asked several, physicians from all around the country. So I went and worked at a field hospital in Billie Jean King. I took care of only Black and Latino patients while there. Those are the demographic people that were marginalized, living in shelters, that needed access to care, but often weren't given means to prevent. They didn't have access to masks. They had people that were telling them, all you have to do is open a window and that will stop COVID from spreading. You can't get it again if you already had it once. We know that very well today is not true, as I'm sure many people have had it already this season. But dispelling myths and trying to improve the lives and increasing the trust and accessing our healthcare system in the Black community was really hard. But we knew we were also having that problem here in Utah, and particularly when it came to vaccination efforts. So when the vaccine was readily available and paid for, and people were almost driving up with a minivan to bring it to your home, you still had folks saying, I don't trust it. And we have very good reasons not to trust often receiving care that seems free in America, particularly for when it's given towards the Black community, because there's often been things that occur to us. We don't need a reference to Tuskegee all the time. There's other experiments and I would like to say travesties that have occurred when it comes to experimentation and exploitation of the Black community in medicine. But low vaccine confidence, mistrust of our healthcare system, and access barriers to COVID vaccination led to actually support from the University of Utah. And we were able to get a number of Black physicians together. One of them I didn't even know before. That was Dr. Cheshire, and we made Black medical community vaccine stories, where we sat together, we all recorded ourselves at our workplaces, and we put together brief 90-second videos that we pushed out on YouTube, Instagram, all social media, any website we could get access to convey to people, get the vaccine. It'll stop you from getting admitted to the hospital. It may not stop you necessarily from catching COVID, but it can stop you from dying from COVID, which our Black community was greatly being impacted while we were dying in droves in larger cities. So Dr. Cheshire, Dr. Jones, Dr. Okiemi this has actually occurred before before I formalized BPOU in March 2021. This is a few weeks before. And then out of that, really honed our mission and purpose. We understood the need for representation. We understood well the need for education and awareness. And we also understood the need to build a community of not only Black physicians, but allies that want to affect change. So, as you can see here, Black Physicians of Utah, we finally started March 2021, where we're a community for Black physician residents, interns, medical students, and aspiring physicians dedicated to not only health equity for the Black community, but all. And so some of that, as I went through representation, this is what the Black Men in White Coats movie went over a little bit. But this is Dr. Cheshire. He's a hand surgeon here, came here a little over a year ago from St. Louis, and he loves it here. But one thing he will often say is, and we hear this a lot, several Black physicians say, if it wasn't for BPOU, I don't know if I would still be here right now. I'm like, wow, we haven't been around that long. You just got here. It's hard at work. It's hard being a Black physician or a physician of color in an all-white space where you feel like you're not understood, where you feel you're constantly being judged. I think that sometimes is definitely a privilege that marginalized physicians, Black physicians, definitely understand. And sometimes our white peers do not, because race is a part of us every day in many decisions I make. I thought about my race when I drove here today. You know, whenever I'm going down the street, whenever I'm often stopping, a security officer going around in the parking lot. So just imagine that is also on physician of color's mind as well in these hallowed halls at the U. And one thing that I took from that film is, if you can see it, you can be it, particularly when I'm going into high schools and junior highs. That spark, because sometimes it's not always, oh, I got to give tons of scholarships and tutoring and access. If it wasn't for my experience at Howard University as a high school student, mind you, I received care from a Black physician, a Black pediatrician growing up in DC. My mother went to a Black doctor, but I didn't think I could. No one was encouraging me to become a physician. No one really encouraged me to go into science. But once I was able to get access to Howard University, I was surrounded by other Black mentors and peers and like-minded high school students that wanted to go into medicine. I said, oh, I can do this. That's what we're trying to create here. This is why the young Black women that are in this shot here, when we were up at ARUP Laboratory this past summer, are all on their path to apply for med school. And then several of them weren't even considering applying a year ago. they were not encouraged, and they didn't even dream of it. One can be because they don't know anyone in their immediate family, but also they weren't seeing a care provider that looks like them. So they don't see themselves in that position. And then, of course, mentorship is a big part of what we do, but we're much more than that. So we connect pre-meds and med students that are seeking career guidance. And this is some of our events here. We have a social that we will, I think this is at 9th and 9th this past August. So we got Dr. Decimo and myself there.
You got your
He's
chickens on.
OB MFM fellow here. We expose to pediatrics as a specialty.
That's good.
Sometimes
That's a little close to
people
your
on the
ears,
peripheral say,
so you
oh,
would
you don't
not
want to go
want
to pediatrics, you won't make a lot of money. No, if you going into medicine for money, I often tell many of my pre-med students, may I introduce you to some of my business school colleagues, because they have far less training and have gotten far more sleep and make more money. But we want to introduce to the med students, because there are many specialties that we are going to continue to be underrepresented in because we're not exposed to them. So one thing that BPOU does is we take allied physicians or those in their specialties here, and we present that to the undergrads and the med students that are in the Valley. So we have students that you'll see in this photo up here that drive up from the new med school in Utah County that never learned about radiation oncology. I mean, how many people learned about it until what their fourth year, and then it's too late? And you're like, wow.
Okay.
Not saying, I mean, I'm sure you all love psychiatry, so I'm sure that's not changing, but it's something that you might have considered maybe if you had some exposure first or second year. That's what I'm trying to do for several of the med students here. Scholarship professional development. And what I often try to do here with our students and also our docs is, but more so pre-meds and the med students, and that is getting to med school and having a successful career physician is more than getting a 505 or higher on the MCAT. They think it's all about academic excellence, and that's all I need to be a great physician. As you're learning now, bedside manner does not come from academic excellence. It comes from being fair, transparent, kind, and respectful. This is part of our professional development curriculum that we have quarterly with our pre-med and med students, so that when they come out, that they aren't in practicing biases, because Black physicians and physicians of color can implement biases as well. They can be racially biased because what system are they being trained in? They're being trained in a flawed system. So I have to make sure that they're aware that they're not going to commit the errors that I am trying to undo and make our white allies more aware of. That's why we have professional development. But one thing so it's not only pre-meds and medical students, but I want to bring attention to, oh my goodness, is that a typo up there? Oh, yeah, I can't even see it. So there's an H missing from mentorship, so I apologize. In GME trainees, and what I want to, this is from an ACGME survey from residents in 2015 to 2017. Yeah, this is only a snapshot, 7 out of about 31 medical specialties, and showing dismissal rates. And Black residents right now account for 5% of all residents in the nation, but often account for nearly 20% of those that are dismissed. So people are graduating from med school, AOA, highly accomplished, like many of your peers. But what is happening when they get into a GME program that they're not getting through? Another stat I often like to highlight is African-American students or Black students represent about 8% of med students in the nation. We're about 5.3% of board certified Black physicians in the nation. So if everyone said, what's the percentage of Black doctors in our nation? It's about 5.3 to 5.4%. This is as of 2021. Now, of course, the Black Men in White Coats movie said that needle hasn't budged much when he talks about Black males. And there's quite a few diversity initiatives that have been going on for decades now, even though affirmative action was been undone as of a little over a year ago. A little under a year ago. But what I want to bring up is how we have 8% representation in medical school, but only 5% that are getting all the way through the pathway to become a physician. There are factors involved, and we can't ignore that race and racial bias, and particularly factors when it comes to giving unnecessary negative attention sometimes to Black trainees or othering them when they're being trained and taught and not given the same opportunity. So it becomes often a toxic work environment for them to feel like they're being nurtured. So thus they get dismissed, or they're not necessarily quitting. And then I don't know how, if you know anyone that's ever been dismissed from residency, it's really hard to get back in because you're kind of blacklisted. So now you got someone with all this debt. They've gotten, say, 3 out of 5 years of general surgery training. And now they have to go to some program that has a vacancy that they didn't aspire to because someone might not have liked receiving orders from a Black man or a Black woman, or they were seen as being aggressive. This is where things that, mind you, I'm speculating a bit, but we have to understand and we have to protect those that are from underrepresented marginal groups, because right under that are Latinos, are the second highest in being dismissed. And what I really want to, I wish I had my little pointer here, but blue is our white non-Hispanic. So they are getting through GME training and being dismissed at a far lower rate. So GE program directors, if there's anyone listening to the call, look at your program makeup, and not saying you need to give special attention to someone from a marginalized or underrepresented group, but just realize they're already at risk for being dismissed. And you program, if something starts to come up, if they're starting to say, I don't like their write-ups, I don't like, I don't appreciate, or it seems like they sit too close to a patient. They're starting to find problems wrong, or they may not be compared in the same lens or the same light as their white counterparts. That's primarily what I wanted people to take from the slide. So does a workforce that resembles the population improve healthcare? Well, actually, it does. So underrepresented and marginalized medical students report a greater desire to practice in minority and underserved communities, although they don't have to, and they're sometimes encouraged to do so, but many do. URM physicians tend to practice in as well minority and underserved communities, and URM patients prefer minority physicians. There's a reason why, and people ask me, you're a physician leader of this group, why do you leave the state to practice medicine? So it might not have big debate in my bio, but I'm still a practicing locum ER doc, although family medicine background, and I practice in remote critical access hospitals, particularly taking care of the Ojibwe people in northern Minnesota and the Navajo in northern Arizona. They, as a group, Native Americans, disparities are far worse. Life expectancy is much lower than almost any other demographic group. Leading cause of death for a Native American male is actually suicide. It's not heart disease. It's not cancer, suicide. So I feel that population sometimes is often more in need of having a competent physician, even if I have to fly out of state. And so that's how I've been addressing and try to improve healthcare in their community while doing it at the same time here, but although not actually practicing as a physician actively in Utah. So in case somebody wanted to know, like, where does he practice? I actually don't, not in the state. I'm licensed here, just don't practice. So does diversity matter when providing care? So this is the part that drives much of our education and our initiatives. We have become a trusted voice in the Black community. We are becoming a trusted voice in Utah. We don't have any political affiliations. We have spoken out when it comes to gun violence, particularly how it impacts our children, how it impacts our schools. We have talked about how vaccine, why would we not want to encourage everyone to get a vaccine that can protect your child from developing cervical cancer? That's something that, we often say, if you try to address and eliminate racial disparities in healthcare, you reduce the cost of care. You take racism out of healthcare or try to diminish it, you reduce the cost of care. So even from a business standpoint, we should be motivated to want to increase representation. But it has been shown, and this is from a study results that was out in LA in 2018, cardiovascular disease outcomes were improved, diabetes and cholesterol screening increased when receiving care from Black providers. It does not mean as well that allied providers can't convey the same culturally resonating message to Black patients. So some of our activities address particularly racial bias and disparities in the healthcare of Black women. So Black women, and came up in the news a little bit more in this past spring and also around June, are 3 times more likely than white women to die from pregnancy-related complications. This has actually led to several of our campaigns, and this is where our step 1. So step 1, representation. See if you can see it, you can be it. Step 2, community engagement. This is where you as providers can get more involved. So we did patient empowerment. This is just through a simple Instagram live video that we did, I think, at the Black Cultural Center. Breast cancer awareness campaigns. We're often going into churches, town halls, community centers to encourage women that you can self-refer to get a mammogram. You don't need to wait for that 3 months for the doctor appointment to be able to get that done. Perinatal mental health screening. We had a big event for this. Well, I say it's a big event. We had over 100 people down at Gateway. Simple screening. Partnered with another nonprofit, provided a little bit of food, went over 2 films that discussed one called Black Motherhood and the other, sorry, the other one live off the film, Where the Bow Breaks. And we had a collection of panelists, mothers that had to deal with postpartum depression. Mothers are told often in a postpartum period to be strong and often not to voice their needs. It's the needs of the infant, the child. And then they're considered or admonished if they do want to address care for themselves. We wanted to say Black mothers, all mothers, because postpartum depression underdiagnosed and undertreated. And we did the same similar with aftershock, but I was more addressing mortality. Colorectal cancer, third leading cause of death for Black men, particularly, and incidence has not really particularly lessened, even though there's been a change in guidelines. And the thing is, as I want to give example here, the providers below, when we did our colorectal cancer awareness campaign, these are not colorectal cancer surgeons. Blessing Oyinyi, who is no longer with Intermountain and left the state, she's a psychiatrist. Okay, you are doctors. You don't need to be from a certain specialty to talk about the importance of breast cancer screening. So you don't have to, we're too siloed in our specialties to think that we can't be in a part of education and awareness for a marginalized group. You are official already in your capacity because you know far more than the public. You know how to dissect information that's evidence-based and to be able to provide it in an easily consumable way. So at Dr. Cheshire, those are 2 surgeons talking about colorectal cancer. I don't think any of them has ever treated. And the last time they probably learned about it was probably med school, maybe a little bit in residency. But it means a lot that they were representing African-American population when they went out to speak and the importance of getting screened. It may be uncomfortable, but it can save your life. And then I spoke about this a little bit about the impact of obesity in the African-American community, particularly African-American women. These are obesity rates, particularly that in Utah. And so that leads to another campaign in our anti-obesity cardiovascular disease awareness. And part of that, oh, man, my little video didn't pop up. Sorry about that. So we've done several 5Ks out in Taylorsville, meeting the community where they are. Many people have never saw that there was a 5K led, not alone by a physician group, let alone by a community of color, trying to encourage activity and increase fitness. And in lieu of time, I kind of want to get through some other things here. We did a whole series on COVID intersections in the Black community and webinar series that we did earlier throughout 22. And this is where we're talking about COVID, not just, vaccine hesitancy and myths, but there was several layers of impact, particularly to the Black economy, particularly when it came to when someone had to take off from work because they had to quarantine, or they were working in a job where they couldn't really afford to take off from work. How does that affect them being able to pay rent and put food on the table? These intersections we discussed quite a bit. And then African Americans and the struggle with behavioral health. We particularly want to address the attitudes towards seeking mental health services, making sure that it's okay to not be well. It's okay to share that you're not well. We created our mental health forums, which is a safe space for the Black community to come to, where they can be vulnerable and confidential to express how they're feeling. And it's always managed by a professional therapist or physician moderating the groups. 80% of Black Americans are very concerned about the stigma associated with mental illness. Once again, I don't want to tell my EAP because that's something associated with my employer. We often try to dispel that myth. What happens with EAP? It's a service that's provided for. You should use it. It's underutilized. And then this is depression prevalence by race in Utah. So particularly, there is a disparate impact when it comes to the African-American community. Of course, all races, we want to improve depression rates and reduce them here in Utah. But they often, because it's stigmatized, and particularly for Black men, are told you have to be strong and you can't show feeling. And we know that many Black men are suffering. So it actually, our mental health committee was birthed out of addressing Black men mental health needs. And so, as I alluded to, we have our Black Men's Mental Health Forum, our Black Women's Mental Health Forum. These occur every month. We have one for Ogden area because BPOU is one of the, I believe, as far as I know, one of the first and only minority physician-led health professional organization or societies here in the state that's trying to address these needs. So our swath and how we're trying to address is statewide. So we know that not all the Black community lives in Salt Lake County. We know we need to address needs in Utah County. So we have a mental health forum that's down as where there's actually a large contingency of therapists that are there. And we've had special events where we're addressing trans or racial adoptees. So we have many white families here that are very loving, but they're white LDS families, and they're often adopting kids that as they grow up, they realize that they're facing problems at school and at work that their parents aren't able to really provide the resources to help them. We are there for them. And of course, back to school mental health. This is an event that we did in August, right before children went back to school. Because of the high rates of suicidal ideation, suicide attempts, we know this all happens once school comes back into session. So we wanted to, and often sometimes parents are saying, why didn't school tell me? Why isn't a school fixing this problem? We wanted to make sure that that parents had the skills to be able to discuss depression, suicide, anxiety with their children, as well as school administrators knowing what's on the parents' minds. So we had breakout sessions to make sure that this wasn't a taboo topic. It's going on and it's killing our children. And we are or the bandwidth at the schools. They don't have enough therapists to talk to all the students. So we need to make sure that what are the signs that parents need to watch out for. And you need to be okay when your child wants to talk about how they're feeling. So that's what we did with back to school mental health. We're going to do it again next year. We're going to do it bigger. Would love psych resident support on that. And then of course, healthcare workforce development. So we do something called Medicine Immersion Day and a clinical job fair. We've done this for 2 years in a row. This is once again about the CUPB, but it's a mini med school rotation or residency. So we have residents from the U spend time with students. Neurovascular. So we want to encourage people, our students from marginalized backgrounds, to become PhDs as well, because not everyone wants to go to med school, take on debt, spend that amount of time. If you want to become a nurse practitioner, we'll give you a mentor. We'll support you on that. If you want to become a PA, we'll support you with that. And what I'm bringing up here is just to show the support of our local partners. And then we, of course, had our with MBA support. So this is from a grant from the MBA. We had our BPO clinical research scholars. We had several of our BPOU mentees. These are sophomores and juniors from Salt Lake Community College, BYU, U of U, that now have a competitive advantage and edge that they can look similar to their white and Asian peers when applying to med school, because now they actually have some research under their belt. We were able to support that. And we also have a longitudinal research training program that we've just developed with ARUP laboratories, but this is recently at our clinical scientist day. A few picks for Medicine Immersion Day. I'm just trying to get so that we can have some time for Q&A. And then step 4 is professional community. I alluded to that earlier. It's often difficult for many Black physicians they sometimes feel as though they're in an unwelcome space. They may not voice it to you, but when we have our doc nights, which we have monthly, which is for Black physicians and allies and preceptors, we join together, we break bread, has been done for centuries as humans, where we can build a bond, build connection, and this helps with retention. So if you're trying to get someone to come, send them to a doc night with BPOU. And then I would almost say a little bit second to last year, legislative action policy. We know there are legislative there are bills coming forth that are not in favor of addressing health equity. They don't want race to be a factor in making a decision, or they want to paint everyone kind of with an individual lens. We need to meet everyone as a certain individual. But as we saw from the Gardner Institute research, there's disproportionate impact on Polynesian, Latino, Native American, and Black communities here in the state, from obesity rates, diabetes, and mental health. So why would we not want to have our legislators support those activities to level that playing field, not only for access, but for treatment? And we're also a organization that serves. So you will often see us, especially if you go to our website for service opportunities. Here's a couple of, there's our mentees. This is just recently at the jazz game we went to. Some of our mentors, there's about 25 Black physician members of our group right now. But this is our impact in 2023. We had over 48 events. I know if you didn't hear about us until today, we've actually been quite active. That's something that, as my wife will often attest, I'm doing something almost every week. So let me know if you want to be a part. We've reached over 1,300 Black and marginalized Utahns that have attended our events. We are frequently doing health and career presentations. So far, we've been to 4 high school and junior highs in Salt Lake County. And we are covered mental health services for 23 underserved Utahns with behavioral health disorders. Mind you, we didn't get the funding really active and going until about April. But if there is a Black community member or patient that you have seen that could benefit from support at our mental health forums, and we have a negotiated rate with several Black therapists, some people will want to share more, just like they will follow the advice of a Black physician more likely. There are over 30 Black therapists here in the state that we can connect them to. And this is our current membership and students. We're growing. Our next steps. So we, of course, want to maintain and grow our efforts through partnership and grants. So thanks again, Dr. Rappaport and Dr. Smith for inviting me here. We want to increase online webinar education for health education activities. There's actually in the works, and they'll have their a social event, Latino Physicians of Utah. I've been working with them for a little over a year to help birth that organization, because the health disparities for the Latino community often mirror, and they're more prominent, and they're much larger, and they have 4 times as many docs. And they increase research and STEM exposure to opportunities for junior high, and to improve vetted, culturally competent physicians, because we know there are no Black primary care physicians currently in the state. I don't practice primary care. My fellow leader, Dr. Baden, she practiced with a special population at IOC, in their population health clinic there. So it takes years to form and to make a physician. We know that quite well. But we understand the need for representation, but we understand more importantly that guiding someone to a vetted, reliable, fair, and fair ally is just as important. And we're trying to grow into Nevada. So thank you. Question. Sorry, I went 6 minutes over. All right, no questions in the chat. Oh, yeah.
Yeah, can you speak about the inclusivity of your organization?
Yes. Yeah, so Black Physicians of Utah. So we have tiers of membership, actually. So we have our members that are our Black physicians that are part of it. But when you go to our page to apply, if you want to support, we have affiliated members. So those are for non-Black physicians that want to support our mission and purpose. And what I often say for that is, if you're willing to mentor a student, if you believe in, once again, wanting to take steps to address health equity, you're not required to do presentations. At the minimum, I want you to be able to aid or guide a future marginalized or Black student into the field. If you can make a commitment to do that for at least 2 30-minute sessions, even virtually a month, you are on board, you are with us. And even more so, if you said, I would welcome seeing more Black patients, especially if they feel they are not being fairly treated. So if you go on our site under the mentorship tab, we have plenty of non-Black physicians that are part of our organization, about 19 right now. And when it comes to addressing community needs, everyone's welcome to our events that are public facing. So when I'm addressing perinatal mental health, it applies to all women. When I'm addressing diabetes, it applies to all diabetics. I just often am giving from a Black physician or African-American experience in taking care of African-American patients, but it applies to all. And so often I say, if you address the needs of the few, you improve it for the many. Yes, great. BPOU.org. You can always just scan it right up there and you can go to us. Yes.
I think this is beautiful. My question has to do with whether BPOU or another similar organization is doing anything to reach out to other physicians or providers to combat unconscious racial bias in medicine. Like, are there any kinds of presentations or fora about people addressing, maybe their own practices where they may be kind of furthering bias in an unaware way
So we have done training. So we have reached out with the Castell group. I think that's a group of nurse case managers and home health nurses with Intermountain. We have also, so we as Black physicians, several law leaders, we have several presentations to make people aware of racial bias, what steps you can take. But in regards to official, like online CME or programming that you can look at on our YouTube channel, we don't really have that, but we do have recorded presentations that we have done general to docs to tell them about racial bias, where it came from and what step, but because the thing is to address it, it's something that has to be done at an institutional organization level where you're working, that they need to support you wanting to affect that kind of change. But I think the biggest thing is sharing one's privilege is one step, knowing that if you are not of the represented group that you are treating, understand that you may have privilege that you can share with them, or you can try to do more to understand what may be their, not restrictions, but barriers or hesitation to not want to follow your advice. When you tell them you need to eat healthier, but they live with their grandmother and that's how their grandmother expresses love to them, and they don't have the means to go like you may have to Trader Joe's and get a healthier meal to control their sodium, to control their weight, to control their blood glucose levels. So we do have training that addresses that. So we've done lectures with I believe to the School of Nutrition here. We spoke to dietitian students because there are biases that they are practicing. These are specialists that physicians are calling on when they want to advise for lifestyle change. So yes, we are, but not, and it's often to a larger group, but we can speak to physician groups. We want to. We're actually, part of our goal is to have it where it's just on our site, where this is racial bias training in Utah by BPOU. But we do have some of that on our YouTube channel. Yes.
Thank you so much for this excellent talk. My question is about retention. So what advice do you give as someone who's chosen to stay in a state where you're a minority? What advice do you give to like your mentees and all who are training in medicine and maybe want to move to a different place where they're more represented? And how do you encourage them to stay in a place where they're less represented?
It often helps if they have a senior leader, a senior leader that is supportive to want them to stay. If you don't have your boss or who you're reporting to that has picked up that you're having grumblings of wanting to leave, having that discussion with them first, I at times I left all the time actually. So I didn't actually take a job here until 2017, but left here. I left here in 2012, came back in 2013, bought a home, but didn't take a job here for another 4 years because I wanted to provide care to more communities of color, and I wasn't getting that need met here. But it then came down to professional development and wanting to be around other professionals. So you don't need to go and create another physician org. I often say one place to start is your particular specialties, local group. So if there's Utah Academy of Psychiatrists, Utah Academy of Pediatricians, that's one place to start. They often will have diverse members or leaders there that you can say, I would like to start a DEI subcommittee or a workshop group that can address inclusion, or can we just have a purpose of fellowship? It has helped a lot by having our monthly doc nights out. So you can create your own group. I think that's one way to do it. But if you're like, well, I only know 2 people that fall into my demographic, so does that mean that I shouldn't stay? I think one other way besides getting your senior leader involved is, can you be part of recruiting efforts? Is that something that's imperative and important for them to change? I asked to be a part of that with Intermountain at the time because I went to their DEI committee in 2016 in 2017. It was all white women. I'm like, oh, wow. So this is the room that's making all the decisions for diversity for Intermountain. Do you think I should? And they actually didn't want me to be on the committee because they wanted me to do more Instacare work at the time. I was an Instacare doc, but that's a whole nother long story with that. So addressing your wherever you're working with, see if you can have their support for developing at least an opportunity for fellowship with like-minded allies. Because it's, we have you don't have to be a Black doctor to go to our doc nights out. We have several non-Black physicians. We are inclusive. If I had an Asian or Polynesian student that wanted mentorship, I will of course direct them and guide them. But of course, my organization and our Black physicians are speaking from a Black experience. So we're often feel that we're more equipped to help, but we can help just about any student.
Well, thank you very much.
Yes. All right, sorry I went over there.
No, you're good.
We're on my COVID stories.
And this is like. So.
Are you meeting with Elizabeth?
I believe so.
Yes.
Yeah, so I'm like, yeah, I left my packet in the office. Hope I didn't grab it.
Oh, no, it's great. Great.
I really like water, so I hope the people do it.
Yeah. I hate being behind the lecture.
But yeah, I can meet with.
Vice chair. So in charge of our.
Let me get a picture.
You get a picture of
Part of me, I bring like. Oh, sweet, you'll be part of the lunch.
maybe the president.
Oh, I'm on your team. Understand what you're saying.